This is Pete Moore on Halo Talks NYC. I have the pleasure of bringing Dr. Munir. He's going to talk about theranostics. We're going to talk about advanced patient access, clinic rollouts, raising debt versus equity, and the new frontier of healthcare. So, Munir, welcome to the show.
Thank you for the invitation and good morning.
Good morning. Well, I'm wearing a New York Knicks shirt, so I just wanted to give a shout out to my my favorite basketball team, and for you to talk about how we are going to extend people's life and happiness and more championships. So, give us your background, and we'll go from there.
Yeah, so I'm a diehard New Yorker as well. I have been in academic practice in New York for more than 30 years until 2 years ago when I joined a outpatient private theranostics group called United Theranostics. And just like you, I'm also a diehard New Yorker. In fact, I'm a diehard Knicks fan. I was at the final game in San Antonio with my son.
Oh, good for you! All right, I got my. I'm gonna bring out my. I'm gonna bring out my Knicks jersey because I was in San Antonio also for games 1 and 2. So we'll use this as a way to basically gloat about our deal and our
Right.
championship. So give us some of your background on your academic side, and then what kind of pushed you to go in and actually start a company, and why you thought that might be better than staying on the academic front.
So academic side, I was fortunate to have several mentors who trained me into there was different aspects of medical practice. As you know, the medical practice has a very two diverse ends of it. One is purely academic, where people while practicing academic medicine do not really realize the patient access and other issues that occur. But then when you are in the private practice and accommodating patient access, you don't realize that you're losing the academic touch, which is where I realized that I need to make that change. So I spent 32 years in various universities in New York, and I was involved in the clinical trials. I was involved in the clinical care, making sure that the patients are not delayed in getting to their appointment, but also reading the scans in a timely manner to report them out. But then I realized that there are quite a few bottlenecks in the academic practice, and the patients are not in the front and center of it. And which is when I met the founders of the United Theranostics, and I saw what they were building, and I could not resist the temptation to pivot and make that change in my life and join the United Theranostics in the outpatient practice. But I have to tell you that one of the things that really appealed me is that while we are front and center focused on patient access, that we are not sacrificing our academic pursuits. In fact, if you look at my CV over the last 2 years, I have been more academically productive than ever before.
Can you just explain to everyone, because before I started researching for our podcast here, what theranostics actually is as a what is the definition of that term?
Yeah, so let me explain. I think I've to explain it in the very simplest terms. I need to compare it to the other treatment modalities, and I will. While theranostics is not necessarily just for cancer, the cancer is a good analogy to provide and provide the simplest understanding. So, if you, for example, have a patient who's getting chemotherapy or immunotherapy, you may do some tests on them, you may do some genetic assessments, but ultimately, the moment you administer it, you have no control over how that patient is going to respond because each individual, one of us, is a unique single individual. And while you may apply the data to the general studies that may have been done, you have no control over personalizing this. Whereas theranostics is where what the simplest way to put it is we treat what we see and we see what we treat. So, in other words, if I have a patient who needs a theranostic service, the very first thing we do is we do a personalized scan. Kind of like, if one of the other ways to give the analogy would be going to a very fancy New York City tailor for your clothing. You may get off the shelf clothing from Macy's or J.C. Penney, but it won't fit you the same way a personalized tailor who would prepare that just for you. That's exactly what Theranostics is. And to close the loop, not only we personalize the treatment by doing the scan first, but unlike any other treatment modalities, once we administer that treatment, we actually track it and we confirm that the treatment went to where our targets were. So if a patient has a 5 cancer sites and we selected those sites by doing the scan first, we don't stop there. We actually go and after administering the treatment, we confirm that administration to those target sites. I don't think any other modalities in the medical space, maybe with an exception of one or two, that are this personalized in terms of delivering the care to the patient.
And how does a patient get into the theranostics, ecosystem? Like, are they referred by someone another doctor that believes stronger in your treatment process or therapies?
Yes, so they typically there are two different ways, and one is we actually increase the awareness by letting the patients know that in case if this is not brought up by your doctors during your consultation, keep in mind that this is a very strong and preferred option for their treatment. But the majority of the referrals still come from either medical oncologists, urologists, radiation oncologists, and sometimes even primary care physicians who are aware of our service. We also get a large number of referrals by the hospitals. And the reason is that while major academic institutions are in the major metropolitan area, patients live far from there. There are data that show that 80% of the cancer care is given in a community setting. So if the patients live 50, 60 miles from their academic center where they went for an expert opinion, but then they tell their their hospital systems, their oncologists that, look, this requires several visits and it takes me 3 hours each way. Can you find a nearby place for me where I can get these treatments? And we have strong connections with the hospitals in major metropolitan areas. So they realize that it is easier for their patients to come to us. And their patients are living 10, 15, 20 minutes from where we are, makes it much more convenient for them.
So you mentioned something before about if there's a doctor that knows you and it's worked with you, or you're not with United Theranostics, that becomes a lead generator. But also, potentially having the patient know or learn about you. So how do you think about United Theranostics? Are you serving the doctor, or are you also trying to create almost like a consumer brand or brand awareness as part of the strategy, if you will?
Yeah, so actually, and this is a fundamental rule that I was also a program director of training in radiology, and I always emphasize that point to our trainees that as a radiologist, we have different constituents to address to. One is, of course, patient is front and center. But the second one is our referring physicians who we need to keep them in the loop. We need to make them aware of what we are doing in providing the service to the patients and try to reduce their burden so that they are willingly partnering in the patient care with us. They're willingly referring the patients to us because we're not throwing every single management step back to them. For example, if the patients have side effects, then we get involved and treat. Not only it should be our fundamental responsibility, but we know the side effects of these treatments better than the referring physicians. And as a result, it makes sense for us to take the charge. And once we do that, the physicians realize that it is their time is very valuable, and we are not simply a referral service, we are partnering with them in the care of patients.
Gotcha. You know, just to kind of clarify, the hospital used to obviously just be the hub for everything. And then there's been a big trend of, outpatient clinics. Um, when you use the term outpatient, is there an idea at some point where the outpatient, four walls that you control could be, a partition of the hospital from a square footage standpoint, or are you trying to get into like the suburban strip centers or medical centers? Are the hospitals basically all losing this, hub and spoke model to groups like yours? Or is there, a way that sometimes you say, hey, why don't we just be in the hospital, but basically like control our own environment?
That's a great question. In fact, I have to say that what really differentiates that hub and spoke model, and that has worked in many areas, right? For example, surgery centers, right? You have a major academic hospital, a university that has 10 or 15 different satellite sites. What they do is that, for example, a surgery patient, if it is a simple surgery, they do it in the spoke model. If the patient requires a major surgery, then they come to the hub. In this instance, because it requires so much infrastructure, it's heavily regulated and it requires specialized staff. The hub and spoke model for major academic institutions is not really working out well. So what they do is that they tell the patients, look, if you need an oncologist, we will provide you at our spoke model where they can come see you. We can even offer you a virtual visit so it minimizes your number of visits to the major metropolitan area. But if you need a theranostic service, unfortunately, we do not have the bandwidth to create 10 different theranostic centers for a single institution. We do that all in our hub model. And that's where the patients start to complain because they say, well, if you're providing me the virtual visit, if you're giving me the convenience of going to your nearby satellite center for everything else, why not theranostic service? And that's when the patients start to either insist on it or they explore and they find, oh, there is a United Theranostic sites in the suburban area. So majority of our sites will be in the suburban area just because of that reason. And for the reason I mentioned that 80% of the cancer care is being given in the community setting in the suburban areas and
Gotcha.
rural areas.
So, as part of reading up on the growth plans for United Theranostics is to have 50 clinics in every state within the next 7 years. Given your role as the chief medical director and officer, as well as head of training and quality control and efficacy of service offerings, how do you feel about that? How does that work from a staffing standpoint? How does that work from a recruiting? For somebody to work under that brand and umbrella, what does that take? And are you pulling people laterally from hospitals, or are you acquiring radiology or oncology groups that are basically saying, hey, I like your business model better, build me a clinic and I'll come work for you?
That's a great question again. So no, we do not acquire the existing models because it is such a unique infrastructure driven enterprise that it's not so easy to acquire, retrofit, and then train the staff that they may not even have a regulatory clearance to deliver these treatments. So the way we work is, this is where our academic side comes in as well. So every single society organization meeting, we are, heavily presenting our data. We have a very unique way of following the patients that not many academic institutions are able to. And that spreads the word that people are recognizing how unique and quality work we do. And so that brings us to the ability to attract the trainees who are about to graduate, also young professionals who are, in a similar mindset as ours, saying that, in order for the theranostic service to grow, it has to be in an independent outpatient model. So that's where the majority of our recruitment comes in, by spreading the word about United Theranostics' unique model and attracting the trainees and young professionals from academic institutions.
So, what are some of the things that you've been pleasantly surprised by, or have scratched your head as you move from academia to running a commercial, high growth, capitalist business?
Yeah, so one of the areas we have realized is that we thought that this could primarily be for delivery of clinical care, but because our model is so robust and we also provide a very unique expertise and infrastructure for everything that is needed for clinical trials. So currently in our enterprise there are 22 clinical trials, and the patients are increasingly becoming savvy in finding the trials and finding our location as a result of it. We are also finding that some of our own competition is not able to manage very complicated cases. Since I have served in the academic institutions, and all of our physicians have come from academic institutions, so we are very comfortable in handling complicated, complex cases. And that's not the expertise that exists across the board. So one of the pleasant surprises is that because of the clinical trials, the referrals to us have increased because these patients want to stay, even for their clinical trials, within where they live. And our ability to provide that access rather than having to force them to go to New York or Philadelphia, in our case in Princeton office, makes it very convenient for them to join. And that has become a significant motivating factors. It also allows us to provide these cutting edge, newly introduced treatments that are not widely available. So we have patients who are traveling not just within the local neighborhood, but when they find that there are only 2 or 3 sites in the country that are offering these trials, patients are traveling from everywhere in the US to come to us.
And when just to clarify, clinical trials are non-FDA approved, prescriptions or medications or procedures that are being tested in order to get to FDA approval.
Yes, so they are not FDA approved, but on the other hand, FDA still reviews these before they're administered to humans. So there is an FDA clearance
Okay.
for us to participate and offer these trials to the patients. But you're right, they are not approved for widespread use in humans yet. So they are being tested first to see if they are effective.
And then does the treatment? If I'm not that familiar with this, but educate us. If I want to get into a clinical trial, I would apply for it based on the fit with what the symptoms I have or the issues that I'm dealing with. Is that covered by insurance, or is this out of pocket that they're paying, or is the drug company paying for the clinical trial because they want the results?
Right. So for the insurance companies, the typical benchmark is the Medicare and Medicaid, and if the Medicare and Medicaid have approved it, then the other insurance companies cover.
Okay.
And one of the requirements for Medicare and Medicaid is that they have to be FDA approved. So that brings us to a point where if we are going through the trials, none of the insurance companies, I should say maybe 99.99% of the insurance companies would not cover them.
So they pay
So they
out
are covered by the drug companies.
by the
Yeah.
drug companies. Gotcha.
Yeah.
Gotcha. And then in closing here, as you look at being a medical director, trying to solve everyone's problems, finding a cure for everything that you can find a cure for. How often do you have to say, no, we're not ready to do that, or that's too speculative? I'm not comfortable with this clinical trial, because I think there's a lot of similarities to entrepreneurs in every industry that maybe try and bite off a little too much and maybe accelerate their growth and maybe can't control it.
Yeah, so that's another good question. What we typically do is we have our own committee that reviews all these trial proposals. And we look at several factors. First of all, as I mentioned, if anything, our academic pursuits have grown even more. So we are constantly reviewing these new treatment options that are not approved yet. And if we don't find the data supporting their effectiveness or data that show that they may be significant adverse effects, then we say no to those. The other part would be that if we already have an existing trial that we are focused on and we have seen good results, if another trial addressing the same disease and same patient population comes in, we feel hesitant in accepting that because we have commitment to our existing drug companies
Gotcha.
that we are going to enroll the patients, and we don't to create a situation where we don't come through in what we had committed before. So we meet on a regular basis, we discuss this routinely, and decide on whether there is a trial that is, first of all, not appealing, or secondly, competing with our other trials that are already in our system.
Great. Well, this has been a great tutorial for me and for our listeners. Congrats on the new position and your vision for where this company's going. And if you want to help us wave the Halo flag, Health Active Lifestyle Outdoors, we're trying to keep people healthy and healthier. So by the time they get to you, or maybe they never get to you, and you can just wave to them because they're so healthy.
Yes, thank you. Yes, and I should have, if I had known that you are a Knicks fan, I would have brought my championship cap
That's
to
fine.
wear with me.
You can just send it to me. Dave will send you the mailing address. Now, just yeah, it was great. Great to meet you. And we'll get this up online, and hopefully we can wave the flag for what you guys are doing. And it sounds like it's giving people a lot more options and convenience and results. So thanks for doing what you do.
Thank you for the invitation to speak. I really enjoy our conversation, and all the best.
All right, go Knicks. This is Pete Moore on Halo Talks, your captain speaking. I am the founder and managing partner at Integrity Square. We've been around now for 15.5 years. We have been helping people like yourselves get capital, do mergers and acquisitions, consulting, strategic advice in the health, active lifestyle, and outdoor Halo sector, trying to help as many entrepreneurs as possible get to the next level and take that inflection point and be the force behind your growth. We are helping companies that have at least $3 million of EBITDA, around $10 million of revenue, and we are positioned to help you get institutional growth capital or to negotiate deals with strategic partners. If you go to integritysq.com/ISQ, you can see our capabilities deck. Happy to set up a consultation at any time. That is free of charge, and we look forward to helping solve obesity, loneliness, and diabetes. Go Halo.